So hopefully now you understand health equity and health disparities. Equity is, and we're all involved in health equity work one way or another. We're trying to, not only do the same thing for everyone, but give a special lift to people who need extra assistance in any number of different ways. So bottom line, there are major negative upstream examples. We've got racism, discrimination, policies, pollution, substandard housing, food insecurity, poor or incomplete basic education, and climate change. I just remembered I wanted to make a point of something that the last video talked about, and that was about Black women and health outcomes. So I think you've heard me say this before, but I want to drive the point home. Historically, pharmaceutical research in particular and medical research in general was focused on white men, middle-aged white men. There are so many reasons why that was. The point I want to take with you is that we're real aggressively bucking that trend. There are national projects like the All of Us, the NIH, National Institutes of Health, All of Us Research Project, which is seeking to gather together at least 1 million people to do a study over lifetime. And that's called longitudinally when you do it over time, to really look at a whole variety of factors. And more, you all remember with the COVID-19 vaccine, they would do the emergency use authorization after studying a smaller sample of people. They wouldn't get the full authorization until they'd studied the health benefits of a very large population. And in fact, I believe it was Pfizer thought they had a good solution for young children, but it ended up it wasn't. But they had to study this in a lot of young children of all races, ethnicities, and places in the country to make sure that this was a uniform outcome. And at the end of the day, the outcome for the Pfizer vaccine, that particular one in young kids, was it really didn't have an effect one way or the other. It didn't have a beneficial protective. It didn't hurt them either. Well, getting the shot might not have been real comfortable, but in any event, it just the juice was not worth the squeeze, if you will. So now we're going to talk about some of the stuff that you learn when you're getting a degree in public health, which are all the different theories, or sometimes they're called models, or sometimes interchangeably, that really drive the science, the discipline of public health, and therefore of what you all are involved in. So each one of the institutions with whom you're employed, assuming you are employed at this point, are using some combination of public health models to inform, to create their intervention. So first off, let's talk about the health promotion model. So this one is based on the idea that people's experiences affect their health outcomes. Health promotion models are focused on exploring people's attitudes about health and individual experiences related to it. According to the theory, one would have to look at people's lifestyles, psychological health, and social and cultural environment to understand most of their health-related decisions. For example, not eating fresh vegetables because one grew up not consuming produce is a way of understanding why someone may suffer from a chronic condition like obesity. So just to underscore that, if you didn't grow up eating fresh vegetables, or if your mom never really convinced you that you had to eat those lima beans, or the broccoli or whatever, then that can grow into a belief that informs your choices throughout life and your decisions, especially around nutrition. So that's the health promotion model. I think I said health belief. I'm sorry, that's the health promotion model. The health belief model suggests that a person's belief of a diagnosed illness combined with their view of a treatment's effectiveness predicts their likelihood of adopting a change. Look at COVID-19. People's belief about how bad getting COVID-19 was going to be, combined with their view of vaccinations or wearing a mask or hand sanitizing, any of those behavioral interventions, predicts their likelihood of adopting change. And then when you add into that the social media influence of, I don't want to say fake news per se, but of different non-scientifically based perceptions of efficacy of treatments and whatnot. So somebody suffers from an illness that is difficult to diagnose. They might find it harder to prioritize treatment for the cause. Think about high blood pressure. Think about, for that matter, colorectal cancer or diabetes. In the beginning, when you have those things emerging as a serious health issue, you don't feel anything. It's the reason we call high blood pressure the silent killer. Diabetes in the beginning, you don't really feel anything. You might episodically feel tired or whatnot, but it's not until you really get into full-blown diabetes that you run into serious trouble. Based on this idea, health practitioners might take immediate action of telling somebody that they're either susceptible or have a serious medical condition. Moreover, they might expect a person to question the medical approach if they don't feel that the symptoms and show apprehension towards medical advice. So again, that not feeling the symptoms and doc, what you want to do to me, I don't want you to do to me, or I don't want to take a medication. I've heard from somebody that can, have this negative side effect. So all of that percolates together. So what follows this initial outcome might be an informed recommendation of the risk factors that can worsen illness or severe cases of non-compliance. Healthcare professionals and leaders must develop strategies based on the health belief model. So, there in a nutshell is a lot of what you all will be doing in the field. So thinking about health promotion in the health belief models. Then we get into the theory of reasoned action and the trans-theoretical model and diffusion of innovation. Let's do trans-theoretical first. So sometimes when a healthcare professional informs a patient about a potential medical condition and educates them about preventive measures, the person may believe them but avoid immediate action. This choice is based on the idea that when somebody receives information about their health, they might think about it for a while before acting upon it. Because of such behavior, the trans-theoretical theory outlines 6 stages that somebody might go through. And those 6 stages are pre-contemplation. Here, the patient doesn't intend to act yet, despite knowing about the medical condition. Contemplation, they're planning to act with intention. Preparation, now they're establishing a course of action and sets a timed objective. Action, they actually act on that plan. And then maintenance, the patient focuses not on not relapsing, or for that matter, on maintaining a plan that could be taking your meds on a daily basis as prescribed within your daily routines. For some individuals, this may last a few months, while others, it could turn into a permanent state. For example, a recovering alcoholic may struggle with relapses and might stay in the maintenance stage their entire life. And then the final step in the trans-theoretical model is called termination, which is an unfortunately negative word, but it's when the patient is actively healthy, no longer interested or needs to return to the old bad behaviors. Now, the example here that I gave you was about an alcoholic, but I think a better one is about smoking. Anyone who's ever smoked, and I did, I'm sorry to say, it's quite a process. I mean, you know, it's not bad for you. Most everybody knows it's not bad for you. But moving through the steps to actually getting ready to quit and then maintaining the quitting behavior and whatnot, it is tough. It is very tough. Talk to anyone who's a spouse of somebody who's quit smoking, and they will tell you it's a long road. So the next one here is the theory of reasoned action. This theory is credited by under the health belief model, but is considered separate. This theory assumes that a person will act a certain way on a health issue depending on their willingness due to subjective norms. The norms are usually the result of social and environmental surroundings and a person's perceived control over that behavior. So again, we've got perception, we've got those social and environmental factors and whatnot swirling around people, constantly influencing their behavior. So for example, a healthcare professional might ask a young man if his close circle of friends thinks he should incorporate exercise into his daily routine. And a medical study done by the Iran University of Medical Sciences researchers used the theory of reasoned action to evaluate the effectiveness of an educational intervention dealing with the breakfast consumption amongst children and adolescents. And then finally, we've got the diffusion of innovation theory, happens to be a personal favorite of mine. This is another theory that falls under the community and organizational participation models. This theory investigates how a new idea or health behavior can be disseminated in a social structure or the community and identifies what influences how quickly the idea or behavior is adopted. So I'm going to totally make this up. If tomorrow Beyonce was diagnosed with breast cancer, that would be frontline news. It would go through the social networks. Everyone would be talking about it. And public health people would be, frankly, taking the opportunity by her candor about having breast cancer, and she doesn't, by the way, lest anyone think I just said that. And we'd be going like, women, you need to go, do your breast self-examination if that's what your healthcare provider wants you to do. Go, to your healthcare provider. Look at things now before you might have a problem. So anyway, the adoption of new ideas depends on the type of innovation, communication channels, time in the social system. The diffusion of innovation model highlights the uncertainties associated with new behaviors and helps public health program implementers consider ways to resolve those uncertainties. So here's another diffusion of innovation, oops, and then a recover. Remember back at the beginning of the pandemic, the Surgeon General said, no, don't wear masks. We need the masks for the healthcare providers. And it seems like it was only a month later, we were being told, wear masks. And then that new idea had to percolate throughout. It had to become a cultural norm and expectation and whatnot, and a behavior that we all adopted and we just did. And now slowly but surely, because right now there isn't a big outbreak of COVID going on, people are relaxing in that behavior. They are, if you will, temporarily terminating the behavior. I can almost guarantee everyone that we will be back to wearing masks this fall and winter. I hope I'm wrong, but I suspect that we probably will. So there are a lot of other theories and models, but these are the big ones. Hopefully for each one of you, something resonated there. So what can be done? In public health, and therefore in the work that you do, there are high-level systemic actions that can be taken, as well as activities at your level as community health worker. So first, here's some high-level changes. We talked about this kind of before when we were talking about upstream, midstream, and downstream. Healthcare leaders and medical professionals can advance health equity by working to improve access to care and reduce the uninsured rates. Additionally, care facilities can implement community outreach efforts and chronic disease management programs to advance health knowledge in affected populations. And in fact, some of you all might be part of those very types of programs. Many, if not all of you, are working on behalf of community outreach efforts, or you will be. So below are other possible solutions. We've got raising awareness among healthcare providers. Raising awareness through education can help address health equity. Improving resource coordination can also help populations most harmed by health disparities. For example, healthcare organizations can help reduce ethnic health disparities by offering cultural competency training to healthcare providers. Increasing health literacy in affected communities, another role that you could be playing. Healthcare organizations can play a pivotal role in increasing the health literacy of affected groups by expanding educational programming. For optimal impact, healthcare organizations should identify the highest risk groups and accordingly target education and support programs. Advancing health equity. So social, racial, and economic inequities cause many examples of health disparities. Healthcare providers can engage with policymakers, urging action to help communities impacted by these factors. For example, they can use health disparity data and evidence-based clinical knowledge to recommend expanding health coverage to individuals with limited healthcare access. And then always providing more resources. Racial and ethnic groups are less likely to have proper access to health resources and are typically underrepresented in the healthcare workforce. Similarly, rural and low-income communities typically have fewer healthcare professionals per capita, per person, than urban and high-income areas. These communities share a common problem: little to no choice regarding where to seek care. So strengthening and sustaining healthcare resources can help providers better serve people in these high-risk areas. And then finally, partnering with organizations. Healthcare facilities can collaborate with agencies, organizations, coalitions, boards, and councils, working on initiatives to address the root causes of health disparities. For example, the American Medical Association works to diversify the physician workforce to reflect communities' racial and ethnic backgrounds. The AMA also funds public health literacy programs. And then after all of this is tracking results. So monitoring and documenting a program's effectiveness and health impact enables healthcare organizations to determine what's working and find improvement opportunities to improve health outcomes for all. So if we do not track what we are doing, we will not know when we're there, when we've had a good impact. And importantly too, if we don't track what we're doing, we can't make an incremental change that may improve an outcome. And this is part of a rapid cycle improvement model where you go, is this working the way we want? No, not quite. Okay, let's tweak this, but let it run a little bit further, see if we get better results. If the results better, do we stop there? Do we tweak it more, and so on? Alrighty, so what can be done at the systems level? Raising awareness among healthcare providers through education can help address health equity, improving health resource coordination, and can help populations most harmed by health disparities. For example, healthcare organizations can help reduce ethnic health disparities by offering cultural competency training to healthcare providers. Increasing the health literacy in affected areas. I feel like this is a duplicate slide.